Welcome. Today we're diving into the world of knee bursae, those small fluid-filled sacs that cushion and reduce friction around your knee joint. While some, like the propatellar and pes anserine bursae, are well known, many others remain underrecognized despite their potential to cause pain. This video will guide you through the anatomy, clinical evaluation, imaging techniques, and the latest in biologic therapies for knee bursitis. Whether you're a healthcare professional or just curious about knee pain, you'll gain a comprehensive understanding of how these structures impact knee health and what modern medicine offers for their management. Bursae are small, synovial-lined sacs strategically placed around the knee to reduce friction between bones, tendons, and skin. There are at least 11 distinct bursae in the knee, each with its own anatomical location and function. While most remain silent, inflammation known as bursitis can cause pain, swelling, and limited movement. Understanding their locations is key. Some are superficial, like the propatellar bursa, while others are deep, such as the suprapatellar or deep infrapatellar bursae. Recognizing which bursa is involved helps tailor diagnosis and treatment, especially since symptoms often overlap with other knee conditions. Bursitis in the knee can result from repetitive mechanical stress, direct trauma, systemic diseases like gout or rheumatoid arthritis, or even infection. Occupations involving frequent kneeling, such as carpet laying or tiling, increase risk for propatellar and superficial infrapatellar bursitis. Athletes, especially runners and cyclists, may develop inflammation in the pes anserine or iliotibial band bursae due to overuse. Sometimes, underlying joint conditions like osteoarthritis or meniscal tears contribute to bursal swelling. Recognizing these triggers is essential for both prevention and effective management. Bursitis often presents with localized pain, swelling, and tenderness. The exact symptoms depend on which bursa is affected. For example, propatellar bursitis causes swelling over the kneecap, while pes anserine bursitis leads to pain on the inner side of the knee, especially when climbing stairs or kneeling. Posterior knee swelling may indicate a popliteal Baker's cyst. Sometimes, symptoms mimic other conditions like meniscal tears or ligament injuries, making clinical evaluation and imaging crucial for accurate diagnosis. Diagnosing knee bursitis isn't always straightforward. Swelling over the patella could be mistaken for gouty tophi, soft tissue tumors, or even patellar tendinopathy. Posterior knee swelling may mimic deep vein thrombosis, popliteal artery aneurysms, or tumors. Medial knee pain can overlap with meniscal tears or MCL sprains. That's why a thorough clinical assessment combined with targeted imaging is essential to avoid misdiagnosis and ensure the right treatment plan. Imaging is a cornerstone in evaluating knee bursitis. Ultrasound is the first-line tool for most superficial bursae, allowing visualization of fluid, synovial thickening, or infection. It's also invaluable for guiding aspiration or injections. MRI is reserved for complex, deep, or atypical cases, providing detailed anatomical information and detecting coexisting pathologies like meniscal tears or osteoarthritis. Radiographs are less useful but can help rule out fractures or calcific bursitis. Proper imaging ensures accurate diagnosis and guides effective management. Ultrasound is widely used for evaluating knee bursae due to its accessibility, cost-effectiveness, and ability to provide real-time images. It can detect fluid accumulation, synovial thickening, and even signs of infection. Power Doppler mode helps identify active inflammation. Ultrasound is especially useful for guiding aspiration or corticosteroid injections, increasing accuracy and reducing complications. However, its sensitivity varies. Sometimes, even symptomatic bursitis may not show clear findings, highlighting the need for clinical correlation. MRI is the gold standard for evaluating deep or complex knee bursae. It provides superior anatomical detail, helps distinguish bursitis from meniscal tears, ligament injuries, or tumors, and is essential for assessing deeper bursae like the suprapatellar or subpapillary. MRI is also crucial when infection, crystal deposition, or tumors are suspected. Although more expensive, MRI's detailed images can be decisive in challenging cases, ensuring the correct diagnosis and optimal treatment. An infection or crystal-induced bursitis is suspected, aspiration of bursal fluid is necessary. The fluid is analyzed for white blood cells, gram stain culture, and crystals. Blood tests like ESR, CRP, and CBC can support the diagnosis but are not specific. Aspiration not only aids diagnosis but can also provide immediate symptom relief, especially in cases of significant swelling or suspected infection. Popliteal or Baker's cyst is a distension of the gastric nemiosemimembranosus bursa, often linked to osteoarthritis or meniscal tears. Adults may experience posterior knee swelling, tightness, or pain, especially with underlying joint pathology. In children, these cysts are usually asymptomatic. MRI is the diagnostic gold standard, but ultrasound is also highly sensitive and practical for guiding aspiration or injection. Treatment of popliteal cysts depends on symptoms and underlying joint issues. Conservative management, rest, NSAIDs, and physiotherapy is often enough for children or asymptomatic adults. Ultrasound-guided aspiration and corticosteroid injection can provide short-term relief, but recurrence is common if the underlying joint pathology isn't addressed. Surgical intervention like arthroscopic decompression is reserved for persistent or complicated cases. Pes anserine bursa is located on the anteromedial proximal tibia, beneath the sartorius, gracilis, and semitendinosus tendons. It's a common source of medial knee pain, especially in overweight middle-aged women with osteoarthritis, diabetes, or valgus alignment. Athletes exposed to repetitive stress like runners are also at risk. Diagnosis relies on localized tenderness and exclusion of meniscal pathology. Patients with pes anserine bursitis typically report pain 4 to 5 cm below the knee joint, worsened by climbing stairs, rising, or kneeling. Tenderness over the pes anserinus insertion is common, sometimes with warmth or swelling. This condition often coexists with medial knee osteoarthritis and is more frequent in women. Ultrasound findings may be absent, but guided injections confirm the diagnosis and provide relief. Management starts with conservative measures: activity modification, weight loss, NSAIDs, ice, and physical therapy focusing on stretching and strengthening. Ultrasound-guided corticosteroid injections offer faster symptom control, with higher accuracy and better pain relief than blind injections. Recurrence is possible, especially if biomechanic factors aren't addressed. Biologic therapies like PRP and PRP plus HA are emerging as promising options for refractory cases. Propatellar bursa sits between the skin and the kneecap, cushioning the area during kneeling or extension. It's commonly inflamed in people with occupations or sports involving frequent kneeling, hence the nickname housemaid's knee. Chronic mechanical irritation, trauma, or infection can all trigger propatellar bursitis. It's slightly more common in men and adults due to cumulative microtrauma. Propatellar bursitis presents as visible swelling over the kneecap, often with pain and tenderness during kneeling or direct pressure. Acute cases may follow trauma, while chronic cases are seen in those with repetitive kneeling. Septic bursitis is more dramatic, with redness, warmth, severe pain, and sometimes fever. Diagnosis combines clinical assessment, imaging, and if needed, aspiration for infection or crystals. Most aseptic cases respond to rest, ice, NSAIDs, and avoiding kneeling. Chronic or recurrent cases may need aspiration and corticosteroid injection, ideally under ultrasound guidance. Repeated injections should be avoided due to risks like skin atrophy or infection. Septic bursitis requires aspiration and antibiotics, while surgery is reserved for refractory or deforming cases. Biologic therapies are being explored for resistant cases. Superficial infrapatellar bursa lies between the skin and the patellar tendon, just below the kneecap. It's prone to inflammation from repetitive kneeling or trauma, especially in occupations like carpet laying or sports like volleyball. Systemic conditions such as gout or rheumatoid arthritis can also involve this bursa, particularly in chronic or bilateral cases. This condition typically presents with localized pain, swelling, and tenderness below the patellar tendon, worsened by kneeling or extension. Acute or septic cases may show redness and warmth. Chronic cases may present as firm fibrotic swelling with mild discomfort. Diagnosis relies on anatomical location, history, and response to palpation, with imaging helping to rule out other conditions. Most cases resolve with rest, ice, NSAIDs, and activity modification. Persistent symptoms may require ultrasound-guided corticosteroid injection, but repeated injections should be avoided in fibrotic bursae. Surgery is rarely needed and reserved for chronic or refractory cases. Preventive measures like ergonomic protection and patient education are key to reducing recurrence. Deep infrapatellar bursa is located between the posterior patellar tendon and the anterior tibia. It's not externally palpable and is more influenced by tendon bone mechanics. Athletes in jumping or kneeling sports are at higher risk. Inflammation results from repetitive microtrauma, tendon overload, or postoperative scarring, sometimes mimicking or coexisting with patellar tendinopathy. Symptoms include deep interior knee pain beneath the patellar tendon, worsened by running, kneeling, or stair climbing. Diagnosis often requires imaging as swelling is not visible. Treatment starts with rest, NSAIDs, and physiotherapy. Persistent cases may benefit from ultrasound-guided aspiration and corticosteroid injection, but surgery is rarely needed. Biologic therapies like PRP are being explored for chronic or resistant cases. Suprapatellar bursa is a synovial-lined structure above the kneecap, between the quadriceps tendon and the femur. In most adults, it communicates with the knee joint, making it a common site for effusion in joint pathology. Its main role is reducing friction during knee motion, but it's susceptible to inflammation from joint diseases like osteoarthritis or rheumatoid arthritis. Upper bursitis often results from intra-articular disorders such as osteoarthritis, hemathrusas, or infection. Symptoms include swelling and discomfort above the patella, sometimes with a fluctuating mass. Acute cases may show tenderness and warmth, while chronic bursitis presents as painless swelling. Diagnosis relies on clinical evaluation and imaging to rule out joint effusion or other causes. Treatment begins with rest, NSAIDs, and addressing underlying joint pathology. Aspiration and corticosteroid injection may be used for persistent symptoms, but repeated injections carry risks. Biologic therapies like PRP, PRP plus HA, and PRFM are being considered for refractory cases, especially with oil-related synovial involvement. Prognosis is generally good with early intervention. Iliotibial band, ITB bursa is a small space between the distal ITB and the lateral femoral epicondyle. It reduces friction during knee motion, especially between 20 degrees and 30 degrees of flexion. ITB friction syndrome is common among runners and cyclists, often due to biomechanic issues like tight ITB or poor hip abductor strength. Patients with ITB bursitis typically experience sharp, localized lateral knee pain aggravated by repetitive flexion extension. Symptoms often start insidiously after increased activity. Examination reveals tenderness above the lateral joint line, and pain can be reproduced with specific tests. Range of motion is usually preserved, helping distinguish it from intra-articular pathologies. Management focuses on reducing mechanical stress and correcting biomechanical contributors. Most patients improve with rest, NSAIDs, and physical therapy targeting ITB stretching and hip abductor strengthening. Ultrasound-guided corticosteroid injections may provide short-term relief in refractory cases. Biologic therapies like PRP are being explored, but evidence is still limited. Beyond the common bursae, several less characterized bursae can contribute to knee pain, especially in cases of diagnostic uncertainty or treatment resistance. These include the lateral collateral ligament, LCL bursa, medial collateral ligament, MCL bursa, subpopliteal bursa, and semitendinosus bursa. Though rarely primary sources of pathology, they should be considered in persistent or atypical cases. MRI and ultrasound are key for detection. LCL bursa, located between the lateral collateral ligament and biceps femoris tendon, may cause lateral knee pain, snapping, or tightness after repetitive varus stress. The MCL bursa between the superficial and deep layers of the MCL can mimic MCL sprain or pes anserine bursitis, presenting as medial knee pain worsened by valgus stress. Both are best diagnosed with MRI and managed conservatively. Subpopliteal bursa, between the popliteus tendon and lateral femoral condyle, may mimic popliteus tendinopathy or Baker's cyst. The semitendinosus bursa, distinct from the pes inscrün bursa, can cause posteromedial knee pain in athletes with hamstring overload. Both are rare but important to consider in persistent knee pain. Treatment is usually conservative, with biologic therapies considered in resistant cases. While most knee bursae are benign and self-limiting, complications can arise if left untreated or mismanaged. Septic bursitis is the most serious, potentially leading to cellulitis, abscess, or osteomyelitis. Chronic bursitis may cause fibrosis, septation, or mimic soft tissue tumors. Hemorrhagic bursitis can occur in anticoagulated patients. Repeated corticosteroid injections risk skin atrophy or tendon weakening. For most knee bursae, conservative management is the first step. This includes rest, NSAIDs, ice, activity modification, and physical therapy. Addressing underlying biomechanical factors such as obesity or malalignment is crucial for long-term success. Patient education and ergonomic protection like knee pads help prevent recurrence. Conservative care is effective in the majority of cases. When conservative measures fail, injection-based therapies are considered. Corticosteroid injections, especially under ultrasound guidance, provide effective pain relief and can confirm the diagnosis. However, recurrence rates can be as high as 20% to 40%, and repeated injections may cause tissue atrophy or tendon damage. Ultrasound guidance increases accuracy and reduces complications. Biologic therapies are gaining traction for resistant or recurrent bursitis. Platelet-rich plasma (PRP), prepared using double-spin centrifugation, concentrates platelets and growth factors to promote healing. PRP combined with hyaluronic acid (PRP plus HA) offers additional benefits, especially in osteoarthritis-related bursitis. Platelet-rich fibrin matrix (PRFM) provides sustained growth factor release. These therapies are promising, but high-quality evidence is still emerging. Biologic therapies are considered in chronic bursitis unresponsive to conventional care, or when corticosteroids are contraindicated. Superficial bursae with oil-related inflammation like pes anserine or perpatellar bursitis may respond well to PRP or PRP plus HA. Deep bursae may benefit from image-guided PRP or PRFM injections, especially in degenerative or post-surgical cases. Individualized decision-making is key. Several randomized controlled trials support the use of PRP-based therapies in pes anserine and oil-related bursitis, showing improved pain relief and reduced recurrence compared to corticosteroids. PRP plus HA has demonstrated even greater benefits in some studies. However, protocols remain heterogeneous, and more high-quality research is needed, especially for less studied bursae like the ITB or LCL. Despite promising results, biologic therapies face limitations: high costs, lack of standardized protocols, and limited insurance coverage. Most studies are small and of lower evidence levels. Future research should focus on large, high-quality randomized trials to clarify the role of PRP, PRP plus HA, and PRFM in various knee bursae. Cost-effectiveness and broader access will be crucial for widespread adoption. Surgery is reserved for cases unresponsive to conservative and injection-based therapies. Arthroscopic decompression is effective for persistent popliteal cysts, especially when intra-articular pathology is addressed. Open busectomy may be needed for chronic, fibrotic, or infected bursae. Surgical outcomes are generally good when both the bursa and underlying causes are treated. Preventing knee bursitis involves addressing risk factors like repetitive kneeling, obesity, and poor biomechanics. Ergonomic protection, such as knee pads and proper training techniques for athletes, are essential. Patient education on early symptom recognition and adherence to therapy improves outcomes and reduces recurrence. Prevention is always better than cure. Knee bursae are diverse in anatomy and clinical significance. Accurate diagnosis relies on clinical evaluation and targeted imaging. Conservative management remains the cornerstone, with injection-based and biologic therapies reserved for refractory cases. PRP and related biologics offer promising alternatives, especially in oil-related or chronic bursitis. Surgery is rarely needed but effective when indicated. Individualized care and prevention strategies are essential for optimal outcomes. Considering biologic therapy for knee bursitis, follow a practical algorithm. Start with conservative care, escalate to corticosteroid injections if needed, and reserve biologics like PRP or PRP plus HA for chronic, refractory, or steroid contraindicated cases. Use ultrasound guidance for precision, and tailor therapy to the specific bursa and patient context. This approach maximizes benefits while minimizing risks and costs. Imaging not only aids diagnosis but also guides interventions and monitors outcomes. Ultrasound and MRI are indispensable for differentiating bursitis from mimics, planning injections, and assessing treatment response. As imaging technology advances, its role in personalized knee bursitis management will only grow, supporting more precise and effective care. Looking ahead, the management of knee bursitis will continue to evolve with advances in biologic therapies, imaging, and individualized care. Ongoing research into PRP, PRP plus HA, and stem cell therapies promises new options for resistant cases. Integration of imaging, biologics, and patient-centered strategies will shape the future of knee bursitis treatment, aiming for better outcomes and quality of life. Summary: knee bursae are complex but manageable with a systematic approach. Combining clinical expertise, advanced imaging, and emerging biologic therapies allows for tailored, effective treatment. While conservative measures remain the foundation, biologics offer hope for those with persistent symptoms. Continued research and patient education will ensure that care keeps pace with scientific advances, improving outcomes for all affected by knee bursitis.